Hi, everyone. I'm just going to give it a little bit longer to let people continue to join, and then we'll get started. Hello, and welcome to the webinar, What's the Latest in Low-Grade Serous Ovarian Cancer? I'm Maggie Nicholas-Alexander, the Senior Director of Gynecologic Cancer Patient Support and Education at SHARE. Please use the chat to let us know where you're joining us from today. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. All participants will be muted during the presentation. Once Dr. Grisham finishes presenting, we will begin the Q&A discussion. Feel free to ask any questions through the Q&A section at the bottom of your screen. Remember that Dr. Grisham is unable to give specific medical advice, so please keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button on the bottom of the screen and selecting the subtitle option. This webinar is being recorded and will be on the SHARE website soon. Now I'd like to hand it over to today's speaker, Dr. Grisham, to introduce herself. We're so excited to have you here today.
Thanks so much, Maggie. It's my pleasure being here, and thank you so much for the introduction. My name is Rachel Grisham, and I'm the section head for ovarian cancer at Memorial Sloan Kettering Cancer Center here in New York, and also the director of Gynecologic Medical Oncology at MSKCC Westchester. My research for the past 12 years has focused on low-grade serous ovarian cancer, a disease that I'm passionate about and that luckily we are really starting to make large strides in helping to better understand how this disease develops and trying to better target it to have better outcomes for our patients. So today I'm going to give an overview about some of the recent insights we've gained over the past decade and how this is changing our treatment of this disease right now and hopefully further changing it in the future through ongoing clinical trials. Just going to start my screen share here. There we go. And thanks for everybody for putting your locations in the chat. I recognize some names there, so it's nice to see some members of our Sloan Kettering community joining the call today. So just to start with, when I talk today, I'm going to be speaking about low-grade serous ovarian cancer. And we say ovarian cancer for short, but when we say that, we're really talking about ovarian, fallopian tube, and primary peritoneal cancer. Now, unlike high-grade serous ovarian cancer, where we believe the vast majority of cases actually originate from the fallopian tube, we do feel that most cases of low-grade serous ovarian cancer are actually arising from the ovarian epithelial tissue, though there is some emerging data showing that more cases may be, again, in the fallopian tube than we realize. But regardless, when I say ovarian cancer, I'm referring to ovarian, fallopian tube, and primary peritoneal cancer. Now, when we think about the different types of epithelial ovarian cancer, of course, there's the most common type, high-grade serous ovarian cancer. High-grade serous ovarian cancer accounts for about 70% of ovarian cancer cases. High-grade serous ovarian cancer is the type that's most commonly associated with the BRCA1 or BRCA2 mutation, with about 20% of patients with high-grade serous ovarian cancer being found to have a germline or somatic BRCA mutation. Now, that type of cancer is almost always found to have a p53 mutation within the tumor tissue itself. And then we have these rarer types of ovarian cancer, including low-grade serous ovarian cancer, which I'm going to speak about today. Low-grade serous ovarian cancer accounts for less than 10% of cases of ovarian cancer. Unlike high-grade serous ovarian cancer, low-grade serous ovarian cancer oftentimes arises from something called serous borderline disease. Patients who are diagnosed with serous borderline disease have this pre-malignant lesion that can make them more likely to later develop low-grade serous ovarian cancer. Some patients with serous borderline disease who have it resected will never have it come back. Others will have it come back as serous borderline disease again, or others will eventually progress to low-grade serous ovarian cancer. When we look at low-grade serous ovarian cancer tumors, the most common alterations we find are those affecting the MAP kinase pathway. That's something we're going to talk about quite a bit today, so more on that later. Other common types of rare ovarian cancers include clear cell ovarian cancer and endometrioid ovarian cancer. Now, these are both grouped within the ovarian cancer family, but for many patients, they're actually arising from endometriosis that has itself fallen onto the ovary, fallopian tube, or primary peritoneum. These clear cell and endometrioid ovarian cancers are the ones that are most likely to be MMR deficient or associated with Lynch syndrome. They're also more common to be found alterations affecting the PI3 kinase pathway within these tumors, such as PIK3CA mutations or PTEN loss. This is a molecular profile similar to endometrial cancer. And so many of our novel targeted drugs targeting these tumors are similar to drugs that we're using in clinical trials for endometrial cancer. Finally, mucinous carcinoma is another rare form of ovarian cancer. And this one is really tricky because a lot of cases that we initially believe to be mucinous ovarian cancer are actually occult GI primaries, meaning that they're cancers that actually originated somewhere in the GI tract, such as from the appendix or the pancreas or the small intestine, and then metastasized to the ovary. So whenever somebody is diagnosed with mucinous ovarian cancer, it is always very important that they've had a complete workup to make sure that they do not have a separate GI cancer that's truly the source, because that can affect how the cancer is treated. When we think about chemotherapy, the type of ovarian cancer listed here that's most sensitive to chemotherapy is high-grade serous ovarian cancer. And we generally think about low-grade serous ovarian cancer as being less sensitive to chemotherapy. However, that does not mean that chemotherapy does not work for low-grade serous ovarian cancer. Chemotherapy has been shown in multiple different clinical trials to have activity in low-grade serous ovarian cancer, but not as high of response rates as what we see in high-grade serous ovarian cancer. But today we're focusing specifically on those patients that have low-grade serous ovarian cancer. So as I mentioned, this is a unique disease. Histologically, it looks different underneath the microscope. Molecularly, it has a completely different mutation profile than what we see with high-grade serous ovarian cancer or these other rare types of ovarian cancer like mucinous or clear cell. And clinically, it behaves differently also. Oftentimes, these tumors are slower growing than high-grade serous ovarian cancer. However, they have a significant impact on patients' lives. And unfortunately, this type of cancer is oftentimes diagnosed at an advanced stage. So therefore, even though these tumors are slower growing, they still have a significant impact on our patient's life. And again, while we consider these tumors to be relatively chemo-resistant, they do have responses to chemotherapy, but generally not as robust as that which we see in high-grade serous ovarian cancer. When we look at the number of mutations that are commonly found in cancers, ovarian cancer falls right about in the middle of the spectrum amongst different types of solid tumors. Now, when we look specifically at serous borderline and low-grade serous ovarian cancer, we see that in comparison to other types of epithelial ovarian cancer, the mutation burden is relatively low. So we oftentimes find very small numbers of actionable mutations in patients with low-grade serous ovarian cancer. We consider it to be a relatively stable, genomically stable disease. This is important for several different reasons. One reason is that when we think about those MSI high tumors, or what we also call microsatellite instability, those tumors that are most sensitive to immunotherapy, these patients with low-grade serous ovarian cancer are unlikely to be those MSI high tumors. They're unlikely to have MMR deficiency. And so we really need to look for other targets outside of immunotherapy right now to help us treat these tumors. It's also important because of this relative genomic stability, we generally over time do not see a large number of changes in the mutation profile of these tumors over the course of a patient's life with this disease. This is different than some other types of tumors, such as lung cancer, where the mutation profile might change very quickly. In low-grade serous ovarian cancer, oftentimes the mutation profile remains relatively stable over time. So if we do find an actionable alteration in a patient's tumor, even if that tissue is from 12 months or 2 years ago, it's likely that that tissue still has that alteration. Now, when we first started looking at patients with serous borderline and low-grade serous ovarian cancer, we oftentimes grouped these patients together because of the rarity of this disease. I'm going to get up for a second and move because my light just went off. We like to conserve energy here. Excuse that interruption. So one of our first forays into trying to describe the molecular profile of serous borderline and low-grade serous ovarian cancer depended on using something called sequenome and Sanger sequencing to try to identify hotspot mutations in patients with serous borderline and low-grade serous ovarian cancer. And what these initial studies found was a high rate of KRAS and V600E BRAF mutations, particularly in patients with serous borderline disease. In fact, we found that those patients with serous borderline disease that had this V600E BRAF mutation were less likely to present with advanced stage disease, less likely to progress to low-grade serous ovarian cancer, and unlikely to ever be treated with chemotherapy during the course of their life. This led us to believe that presence of a V600E mutation likely was prognostic of improved outcomes for patients with serous borderline disease. Similar studies have now also been conducted at Johns Hopkins and MD Anderson, which found similar findings that these patients that have a V600E BRAF mutation generally do better, and if it's found in serous borderline disease, are less likely to progress to low-grade serous ovarian cancer. This is important because for our patients with serous borderline disease, of course, they want to know how likely is it that this will return as low-grade serous ovarian cancer? What can we know to help to predict what the future will be? So this is one tool that can help us. Now, in this case, this mutation was identified via sequencing. However, since this time, we've developed a IHC assay that can be used on the tumor tissue itself to relatively quickly determine if patients have this mutation in their tumor cells. And that we now perform this as a standard of care in all of our patients with newly diagnosed serous borderline disease to try to provide some prognostic information for our patients. Now, as I mentioned, these earlier studies that we did that first started to describe the mutation prevalence in serous borderline and low-grade serous ovarian cancer were focused on relatively limited sequencing platforms. So in this case, sequenome, which looked at hotspot mutations, mutations that have been well characterized, and then also Sanger sequencing. Now, since that time, our understanding of tumor sequencing has really evolved quite a bit and allowed us to make much deeper insights, not only into how the disease functions across the large greater population, but also in order to be able to tell patients specifically more about their tumors and what treatments they may be more likely to respond to. So I've mentioned these mutations like KRAS mutation and BRAF V600E mutation. These are mutations in a pathway called the MAP kinase pathway. So the MAP kinase pathway is a cell signaling pathway that, when activated, leads to cell growth and prevention of cell death. So when this pathway is activated in a cancer cell, this light switch is turned on that makes that cell just keep reproducing and not die. So if you can target that pathway and inhibit it and turn it off, you can then allow for cell death of these cancer cells, which is what we want. So oftentimes, since we know that we have activation of this MAP kinase pathway in patients with low-grade serous ovarian cancer through KRAS mutations or other alterations affecting this pathway, it can help us to better determine what type of drugs we should be using to try to inhibit this disease. So one of the very first clinical trials that tried to leverage this information that we have about there being MAP kinase alterations in low-grade serous ovarian cancer was GOG 239. So this was a study of an early generation MEK inhibitor called selumetinib. And this study enrolled patients with recurrent low-grade serous ovarian cancer who had measurable disease, meaning at least 1 centimeter tumor nodule or 1.5 in the smallest dimension if it was a malignant lymph node. Patients who enrolled to the study were treated with this oral MEK inhibitor, selumetinib, and remained on treatment for as long as it was working or unless they developed bad toxicity. So as we say, until progression of disease or intolerable toxicity. And that study found that amongst those patients treated on that study, there was a 15% response rate. So 8 out of 52 patients had what we call a RECIST response, which means 30% tumor shrinkage or more. And at the time, this was considered to be a really good response rate, since historically, the response rate to chemotherapy or hormonal therapies like aromatase inhibitors is generally considered to be less than 15%. Now, it's really important when we do a clinical trial to try to gain as much as possible from it. Every single patient that enrolls onto a clinical trial is making a huge sacrifice. As some of you may know, as you might have participated in clinical trials, being on a study almost always requires more work than if you were receiving standard of care therapy. You usually have to come in for extra visits, have extra bloods drawn, you might have CAT scans done more frequently, there might be tumor biopsies that are performed. And so, the benefit of that is that this information is collected in a prospective way that allows for it to be very reliable information that we can then use to not just get the primary outcomes of the study, but we want to be able to use that information to get as much useful information as we can to empower patients to know about their disease and to be able to find pathways forward for new ideas for better treatments for the disease. So although this was a relatively small study, we wanted to make sure that we were learning everything possible from those patients that had committed their time to enroll to the study. So one patient that was treated on that study was treated here at Memorial Sloan Kettering Cancer Center. And it was a woman who had been diagnosed with low-grade serous ovarian cancer several years earlier, had gone through multiple different surgeries, chemotherapy, intraperitoneal chemotherapy, endocrine therapy, and ultimately enrolled to the study, started the selumetinib, and had a complete response. So after multiple prior lines of therapy before she went on this study, and her cancer became so small that we couldn't see it. And that was more than 14 years ago, and she remains on the clinical trial. She's still taking that same drug. The study ended years ago, of course, but the drug company continues to provide the drug because she continues to respond. So this was a patient that we call an extreme responder, a patient that's had fantastic outcomes from treatment with a targeted drug. And so we want to know, why did she have fantastic outcomes, and how can we help to figure out who those patients are that are most likely to have these really strong responses to MEK inhibitors so that we can get this drug to those patients. So what we did with the patient's consent, of course, was look at her archival tumor and used a newer type of sequencing to evaluate this tumor tissue called next generation sequencing, which since that time has now become a standard of care, but back at this time was something we were still doing in a research laboratory. And identified through that sequencing a deletion in a gene called MAP2K1. And we were then able to use structural modeling to predict how that gene mutation was affecting the shape of the protein that it codes for. Now, this was important because it allowed us to predict how this altered protein may potentially make a cancer cell likely to keep growing. And based on this formation, we felt that this alteration was leading to activation of the MAP kinase pathway and triggering phosphorylation of a protein called ERK. So we subsequently developed cell cultures that had this same alteration and showed that the cells that had this alteration grew much more quickly and more strongly than cells that did not have the alteration, meaning it was oncogenic. And showed in these plots that the cells that had this alteration had higher levels of this phospho-ERK, that the ERK was phosphorylated, and then also showed that you could inhibit this pathway by treating with MEK inhibitor. So this was a great way for us to learn about how this alteration might make patients with low-grade serous ovarian cancer more sensitive to treatment with MEK inhibitors. Now, this sequencing, which now is called here at our institution MSK Impact, is now a standard of care option for all patients. And we can use this information in so many different ways. Here at Sloan Kettering, we offer this sequencing to all of our patients with newly diagnosed or recurrent ovarian cancer. And this allows both patients to know if they have a mutation, and then also we can put this information into a database, which can then be triggered to let us know if there's a clinical trial available that targets an alteration that a patient has. There are also other commercially available assays that can be used at other institutions, such as Foundation Medicine and others that also use similar sequencing platforms and are available to much of the population worldwide. Now, that's one example of an alteration that we found in an extreme outlier. But there are other alterations that we've found in patients with low-grade serous ovarian cancer as well, such as this patient who was treated on a clinical trial we were running with a MEK inhibitor and weekly Taxol and had an extreme response. And subsequently, through deep sequencing of her tumor tissue and other analyses, we found her to have a novel BRAF fusion that had not previously been identified. But then when we went through our archival database of other patients with low-grade serous ovarian cancer tumors, we were actually able to find a whole slew of different alterations affecting the MAP kinase pathway that we had not previously been looking for when we were just looking for these hotspot mutations like KRAS or BRAF, allowing us to better understand the extent to which this pathway is altered in patients with this disease. So it's good to understand why a cancer is forming and what makes it grow. But the reason we really want to understand that is so we can target it and treat patients and have good responses. So the next two clinical trials were our big forays into trying to treat patients with low-grade serous ovarian cancer with MEK inhibitors and on a large scale to see how effective they were. So I'm going to describe two different studies. The first one is called the MILO study, or MILO and GOG 11 study, which was open across the world in multiple different countries. This study initiated in 2013 and closed in 2016. It enrolled 341 patients, and thus far has been the largest prospective clinical trial ever performed in low-grade serous ovarian cancer. So this study enrolled patients with recurrent or persistent low-grade serous ovarian cancer, and patients had had at least one prior line of chemo, but they couldn't have had more than 3 prior lines of chemo. And then patients were randomized to either treatment with a single agent binimetinib, this one is called, a single agent MEK inhibitor, this one is called binimetinib, or to treatment with physician's choice of chemotherapy, where the physician and patient would choose together which chemotherapy was most appropriate for that patient. And the choices could have been pegylated liposomal doxorubicin, which is also called Doxil, paclitaxel, or topotecan. So this study, unfortunately, closed in 2016 when an interim data analysis showed that the PFS analysis had crossed the predefined futility boundary, meaning that the PFS was similar between the two arms. But again, even though that study closed early, we want to learn as much as possible from this study. You know, over 300 patients sacrificed their time to enroll on this study, and we want to make sure that we're obtaining as much information as possible from this study that was performed. So because this study was performed across the world, we have the advantage that the patients that were enrolled to this study were a somewhat more diverse population than what we've enrolled to with our patients that have been limited, to our studies that have been limited to the United States population. Overall, over 100 patients donated their tumor tissue when they enrolled to this study to allow for it to undergo sequencing to look for alterations using this next generation sequencing. In this study, it was done using a platform called Foundation Medicine, which is a commercially available platform. And it found that amongst patients who had a KRAS mutation, one of those mutations that affects the MAP kinase pathway, for those patients that were treated with the MEK inhibitor, binimetinib, the progression-free survival, meaning the time that the patient stayed on treatment before their cancer progressed, was significantly longer if the patient had a KRAS mutation. So for those patients that had a KRAS mutation, 17.7 months versus 10.8 months for those patients that did not have a KRAS mutation, or what we call KRAS wild type, meaning not mutated. Now, for the patients that were treated with physician's choice of chemotherapy, there was also a non-significant trend towards longer PFS in those patients with a KRAS mutation, 14.6 months versus 11.5 months, indicating that having a KRAS mutation appears to be prognostic, that patients that have a KRAS mutation, no matter what they're treated with, might do a little bit better. But amongst those patients that are treated with a MEK inhibitor, those with the most robust responses were those with a KRAS mutation. Though it's important to note that there was activity seen both in patients with and without a KRAS mutation. Amongst those, in that primary publication, we also showed that the response rate for patients with a KRAS mutation was 44%, versus 19% in those patients that were KRAS wild type. And again, when we're talking about response rate here, this is using that RECIST criteria that's used in clinical trials. So a response means 30% shrinkage or more. So amongst those patients that had a KRAS mutation that were treated with a MEK inhibitor, 44% of them had 30% shrinkage or more. And amongst those that did not have a KRAS mutation, KRAS wild type, 19% of them had a 30% shrinkage or more. So still a good response rate, but more robust in those patients that have a KRAS mutation. We did a further analysis of this looking at MAP kinase alterations in general, so not just KRAS mutations, also NRAS mutations and BRAF mutations and NF1 mutations, so other alterations in this same pathway, and found pretty much the same effect across alterations affecting this pathway, where we see the same trend towards improved response rate in those patients that have a MAP kinase alteration versus those that do not. But again, with responses both in those patients with a MAP kinase alteration and without. meaning that we think that this alteration is prognostic, but it's not predictive. It doesn't tell us, oh, you should get a MEK inhibitor and you shouldn't, because both populations of people, those that have a mutation and are wild type, can derive benefit and have responses, but it can give us prognostic information. So another study that was ongoing at the same time, GOG 281, was a very similar study. So this study again enrolled patients with recurrent low-grade serous ovarian cancer who had measurable disease. The key difference here was that these patients were a more heavily pretreated population. Patients, again, had to have had at least one prior line of chemo, but there wasn't a limit on how many lines after that they could have had. So about half of the patients that enrolled to this study had had 3 or more lines of therapy. Patients here were randomized to either treatment with a different MEK inhibitor, and this time called trametinib, or standard of care therapy. And here it had those 3 chemo options that were available in the other study, MILO, so liposomal doxorubicin, paclitaxel, or topotecan. And 2 of the other options were endocrine or hormonal therapies, so letrozole or tamoxifen. So patients enrolled to this study, if they were randomized to standard of care, could have chosen in conjunction with a discussion with their physician to either be treated with chemotherapy or with a endocrine therapy like letrozole or tamoxifen. And patients remained on study again until either they progressed or had side effects that made them come off study. So as I mentioned, this was a more heavily pretreated population, with half the patients having 3 or more prior lines of therapy before they enrolled to this study. But this study did meet its primary endpoint, and it showed a significant improvement in progression-free survival for those patients that were treated with trametinib versus those patients that were treated with the standard of care chemotherapy or hormonal therapy. And the difference in progression-free survival was 13 months versus 7.2 months. So looking across both of these studies, what we see that is we gained a lot of important information. We gained information about what to expect with standard of care therapies, because we didn't have a lot of good prospective information about that before these clinical trials were done. A lot of it was retrospective data. And honestly, a lot of the retrospective data had predicted that the response rates to chemotherapy were going to be lower, because there was a lot of retrospective data saying response rates to chemo would be 4% or lower. And so when we saw these higher response rates to chemotherapy, it somewhat affected our statistical design. But that was, it's one of the challenges in a rare tumor study, is that you don't always have a lot of prior information. So this gave us important information about standard of care therapy. It gave us really important information about expected response rates to single agent MEK inhibitors, and has given us important information about how tumor profiling, determining the molecular alterations in somebody's tumor, can help us to predict how they are going to respond to a treatment. And so that's really important information. So looking across these 2 studies, one where in one study patients had more prior chemo than in the other, and so the response rates to standard of care therapies ranged from 6 to 13% across these 2 studies, and then the response rate to single agent MEK inhibitor ranged from 16 to 26%. So that's good. We were happy to have a new option for our patients with low-grade serous ovarian cancer, and so based on the response of these studies, trametinib and binimetinib are now included in the NCCN guidelines, which is our national comprehensive cancer network guidelines for what we feel are the appropriate or acceptable treatments for all different types of cancer. So we have NCCN guidelines for all different types of cancer. And so amongst the ovarian cancer guidelines, the low-grade serous ovarian cancer guidelines now include trametinib or binimetinib as options for patients with low-grade serous ovarian cancer. So great news that our patients have that option in the United States, at least. We still have challenges abroad, but we need better response rates, right? That's good. That's some advancement, but it's not enough. So we need to find a way to have more patients responding, and we need to have deeper responses, because this isn't good enough yet. So our next generation of clinical trials is looking to see how can we improve upon these response rates that we see with single agent MEK inhibitors. And so this is a study that I'm very excited about. Now I'm going to talk a little bit about a phase 1 study that was called the FRAME study, and then I'm going to talk about an ongoing phase 2 study called the RAMP 201 study. I should note that I am the national PI of the RAMP 201 study, and so have, would like that study to do well. So I am disclosing that information. So the FRAME study was a phase 1 study that looked at a combination of a dual MEK-RAF inhibitor plus a FAK inhibitor, with the idea of trying to enhance the efficacy of a dual MEK-RAF inhibitor in patients that have cancers that are sensitive to MEK inhibitors. Now, a dual MEK-RAF inhibitor means that we're inhibiting both MEK, so like MEK inhibitors, we just saw a couple examples of those, trametinib, binimetinib, selumetinib, those are MEK inhibitors. There's another type of drug called a RAF inhibitor, such as vemurafenib, that inhibits RAF, which is another component of that MAP kinase pathway. So a dual MEK-RAF inhibitor is inhibiting with one drug both MEK and RAF. So we've got a drug that's trying to hit two parts of that pathway. And then a FAK inhibitor is a second drug to throw in there to try to prevent resistance from developing. So when you inhibit one pathway, we have other pathways that try to compensate for it and get around that pathway being inhibited. And so it's always important when giving a targeted drug to be predicting how that resistance is going to develop and then trying to inhibit that resistance from the beginning so that your drug works as long as possible and you have a response as long as possible. So this FRAME study, which was open to multiple different solid tumors, including low-grade serous ovarian cancer, amongst those patients with low-grade serous ovarian cancer, in this phase 1 study showed really promising results for this combination, with patients both with MAP kinase alterations and without MAP kinase alterations having really deep and durable responses. The other thing that was really interesting, which was seen in this initial FRAME study, was responses in patients who had been previously treated with MEK inhibitors. So this is a plot that shows best tumor response. So it's amount of shrinkage for each one of these individual patients that was treated on this FRAME study. So for example, this patient had about 70% shrinkage of their tumors and they have a KRAS mutation. So for each one of these individual patients, if they have these lines, these crosshatches going down their column, it means they had already been treated with a MEK inhibitor before. So they had either been treated with trametinib or binimetinib or selumetinib, either on clinical trial or through a standard of care treatment. And despite having come off that treatment, in most cases for progression, they still responded, had tumor shrinkage with this combination. So it's really exciting to think that this might be a possible post-MEK progression option, or for people that have never had a MEK inhibitor, perhaps potentially an option that is more active than MEK inhibitor alone, right? Because we want the best responses possible. And many patients on that initial phase 1 study remain on treatment now. So based on the results of that study, the FDA in the United States granted breakthrough therapy designation to this dual MEK-RAF inhibitor, VS6766, in combination with defactinib for recurrent low-grade serous ovarian cancer, which allowed for this pathway to try to expedite drug development of these drugs. It can take so many years between the time that a drug looks promising in the lab until it becomes available to patients. And so we try to take advantage of these opportunities when possible to try to accelerate that process so that we can just try to get drugs to patients as quickly as possible, because nobody wants to be waiting around for years for a clinical trial process and then to be reviewing that clinical trial process for any longer than it has to. So that led to the development of this ongoing phase 2 study, GOG 3052 and GOG 60, which is called the RAMP 201 study. So this is a study looking at patients with recurrent low-grade serous ovarian cancer with measurable disease. They're allowed to have had one prior line of MEK inhibitor, and treating patients with either this dual MEK-RAF inhibitor, VS6766, or dual MEK-RAF inhibitor plus defactinib, and looking at two different cohorts of patients, those patients with a KRAS mutation and those patients without a KRAS mutation, to try to better learn about how response rates and progression-free survival are in those two populations, because we know from our prior experience on these other clinical trials that patients with a KRAS mutation might respond a little bit differently than patients without a KRAS mutation. And so some initial results from this study have been not presented yet, but released on the website for the company, which initially are showing good tumor shrinkage. Now, again, these are just results that have been released by the company and have not been formally presented yet or published. And so we should wait for the presentation and publication before we draw any strong conclusions. But initial data looking very promising for seeing similar tumor shrinkage to what has previously been reported in the FRAME study, which I'm very excited about as this study continues. So just switching gears for a minute, I just wanted to say that, you know, in studying rare diseases like this, low-grade serous ovarian cancer, we really need to come together and work together across the world to try to make these studies happen and to try to learn and gather information as quickly as possible. And so it's so important to have groups like this that bring patients and advocates and family members together to try to spread the information, to try to find out what clinical trials are available, to try to find out what's changing in the treatment of a disease, and just to really all work together because we've all got the same goal here. And so one example of someone that's beautifully really brought people together is Jane Ludeman and her family, who worked with David Gershenson at MD Anderson Cancer Center to develop something called the ICLC, which is an international consortium of researchers who study low-grade serous ovarian cancer. So this includes scientists and physicians from across the globe who really just work together to try to make sure that we're furthering research and benefiting from each other's research and just trying to accelerate the process as much as possible. And through this group, we're working to develop a new clinical trial platform to hopefully bring more studies to low-grade serous ovarian cancer patients quickly, working on a potential patient registry, working on different projects to just try to bring our patients and physicians together. And this is across multiple different organizations from New Zealand, MD Anderson, Sloan Kettering, Hopkins, and I think is a really nice example of how we can come together within these rare diseases to just be all on the same team. And I think that we've done that across a lot of other solid tumors, but we can do better. And it's something that we just have to keep challenging ourselves to work together and collaborate and try to accelerate research. And so finally, I wanted to, of course, thank our wonderful patient advocates and everybody that works so tirelessly, whether it be through spreading patient information, building websites, donating their time, donating resources, cycling for our Cycle for Survival team, doing all these different things that so much of our patients and families have committed their time and efforts to try to help us to get better options for the future. So thank you.
Thank you so much, Dr. Grisham. That was a great presentation. And so now we're going to get started with the Q&A. You can still submit questions in the Q&A section at the bottom of your screen. We will try to get through all of the submitted questions, but we may not be able to due to time constraints. All right, so this person is asking, when should someone with low-grade serous consider a second or third surgery?
That's a great question. So, I'm a medical oncologist, so I didn't talk too much about surgery here. But that's a really important question because surgery is a much bigger part of low-grade serous ovarian cancer than it is for high-grade serous ovarian cancer. So in high-grade serous ovarian cancer, oftentimes patients just have their primary surgery. There's a select group that have a secondary debulking and a even smaller group that have a tertiary debulking, but almost it's pretty rare that we go past a tertiary debulking with high-grade serous ovarian cancer. Now, low-grade serous ovarian cancer is a disease where we never really stop considering surgery. It's something we always want to be weighing. And so it's always important that a patient with low-grade serous ovarian cancer continue to be followed by their gynecologic oncology surgeon. So patients that follow with me, a gynecologic medical oncologist, also follow with a gynecologic surgeon. And we work together. Each time that there's a symptomatic progression, we think about, is this something that would best be treated with systemic therapy, or is surgery something we should be considering? And the reason it's so important is because of, that being less sensitive to the chemotherapy is an important factor. And we don't want our patients to develop obstructive symptoms. If something is slowly growing over time and then has a risk of obstructing the bowel or bladder, and we can prevent that or significantly delay that from happening with surgery, it is something we should be considering. Of course, surgery comes with risks, no doubt, risk of poor wound healing, bleeding, infection, fistula, all these things that can occur. But I would say for my patients with low-grade serous ovarian cancer, we always consider surgery at time of first recurrence. We consider surgery if there's a potential obstructive event that could happen, like a bowel obstruction, or any time where the disease appears to be somewhat localized in its growth. So I think it is important to continue that relationship with your surgeon and to consider that more often than we would with high-grade serous ovarian cancer.
Great, thank you. And this person is asking whether CA-125 is less of a marker in recurrent disease for low-grade serous.
Yeah, that's another great question. Thank you. So yes, that it is. So CA-125 is less predictive in low-grade serous ovarian cancer than it is in high-grade serous ovarian cancer. This was found in a clinical trial with Amanda Fader, amongst other prior retrospective studies. And so, we still look at it. I still measure it in my patients with low-grade serous ovarian cancer. I think there's a little downside to that. But here's the key thing, and this is something I've seen done, what I feel is incorrectly before. I would not monitor someone with low-grade serous ovarian cancer with CA-125 alone. If somebody had advanced stage disease at time of diagnosis and has completed their adjuvant therapy and is now on follow-up, there's some people with high-grade serous ovarian cancer that are followed with just CA-125 and then scan if CA-125 elevates. For someone with low-grade serous ovarian cancer, I don't think the CA-125 is good enough to be able to make those decisions. And so for my patients who have advanced low-grade serous ovarian cancer at time of presentation, I will follow them with routine scans because I just don't think the CA-125 is good enough to drive those decisions.
Mm-hmm. That makes sense. And sort of a question someone else was asking, what is sort of your opinion if the CA-125 is rising, but the scans and everything show no sign, it shows that disease is stable?
Yeah, so as we all know, the CA-125 can be affected by a lot of different things, right? It's everybody has a CA-125 value. It doesn't go to zero. There's some number in any patient that you measure it on, whether they've ever had cancer or not. And as we just said, it's not as predictive in low-grade serous ovarian cancer. So I really go by the scans more. So if somebody's scan is stable and the CA-125 is going up, I generally feel that it's best to wait until there's a radiographic change before you change treatment. Partly because we only have so many lines of therapy, and if there's no radiographic change, it's unlikely you're going to benefit somebody by quickly going through all of their available lines of therapy based on just CA-125. You're more likely going to drive tumor resistance and limit their options for the future. And so I think it's best to wait until there's a radiographic change. Now, sometimes when the CA-125 is going up, that is because there's more microscopic cells that are floating around. But luckily, those microscopic cells are not the ones that are hurting us, right? It's the ones that are big enough to see, that are growing, that have the potential to cause harm. And so I think it's better that we reserve our change in treatment for when there's that tumor growth that we can see.
Mm-hmm. Great, thank you for that. And so this person is asking about NRAS versus KRAS, and their question is, are treatments showing success with KRAS also effective for NRAS, because they feel that they hear more about KRAS?
Yeah, no, it's a great question. Yeah, and it's been kind of a hot topic, especially with the RAMP 201 study going on, because it limits to the KRAS mutant and KRAS wild type cohort. So having that as an inclusion criteria was frustrating for some of our patients when the KRAS wild type cohort closed and you need a KRAS mutation, because really, and what we've learned from doing this MAP kinase alteration analysis from the MILO study is that we see the same trends across all MAP kinase alterations. So yes, I think that an NRAS mutation is likely just as predictive of response as a KRAS mutation. And so, whether it's, a BRAF mutation, an NRAS mutation, a KRAS mutation, I think these are all good prognostic indicators. And so I would really group them together into the greater family of MAP kinase alterations. But for various reasons, sometimes a clinical trial or something like that will limit to KRAS mutation. A separate topic would be that there's a separate class of drugs that specifically inhibits a certain type of KRAS mutation, KRAS degraders. And that's being considered for some phase 1 clinical trials right now, and some of those might have spots open for low-grade serous ovarian cancer patients. If it's a drug that's specifically a KRAS degrader, then yes, you need to have a KRAS mutation. But when considering just the use of a drug like trametinib or binimetinib, I would consider KRAS and NRAS to both be similar prognostically.
Mm-hmm. Great, thank you. And we're getting some more questions about scans. And so this question is about whether there's a specific type of scan that better shows low-grade serous growth.
Yeah, so it can be a little tricky, because with low-grade serous ovarian cancer, we get these calcifications, right? It has the disease. When you look at it under the microscope, it has these simomatous calcifications. And then when you look at it radiographically, it can also have these calcifications. In general, I feel the best scan for most patients with low-grade serous ovarian cancer is a CAT scan, a CT scan. There's sometimes, because the low-grade serous ovarian cancer is a bit slower growing, it may not be PET avid. And also, PET scan is not the best way to evaluate for a change in size of lesions. And what we're really looking at for is to see if things are growing by millimeters or decreasing by millimeters. And CAT scan is generally our best way to see that. Definitely there's imperfections with any imaging modality. But for some reason, and for various reasons, we might use a different imaging modality, such as if somebody has serous borderline disease and does not have cancer that's progressed to low-grade serous ovarian cancer, we might follow that patient with ultrasounds, or in certain cases, MRI, because of course there's the risk of radiation and contrast over the course of somebody's life, particularly in somebody who's young and doesn't have a diagnosis of invasive cancer. But for somebody that has low-grade serous ovarian cancer, generally CAT scan is my preferred scan.
Mm-hmm. Great. And then one other question about scans is just around the frequency that people should typically be scanned.
Yeah, it depends, of course, on your individual situation, of course, and everybody's different. And the best predictor of when I'm going to say somebody's next scan is what their last scan looked like. And so we have to take into account what the scan looked like and whether there were indeterminate findings or whether there's something we're watching. But in general, so I'm going to say as an example for somebody, let's say, who's had newly diagnosed low-grade serous ovarian cancer, stage 3, and has completed their surgery and adjuvant therapy and is on follow-up, I would generally do a CAT scan every 6 months, but it can vary from person to person, of course.
Great, thank you. And so this person is asking whether there are any studies looking into CHEK2 mutation and its connection to low-grade serous.
Yeah, I'm guessing that person maybe has a CHEK2 mutation. Because of course you want to, when we do this sequencing, you want to know, right? Because it is empowering to have these alterations. And so it's good to have that information and to be looking. We don't have a specific study that I know of in low-grade serous ovarian cancer right now, but when somebody has a specific alteration, it's always good to be thinking about phase 1 studies also and talking to your provider about what phase 1 studies might be available. And if your site doesn't have phase 1 studies, sometimes in your geographic region, there might be a larger referral center that has a phase 1 center. Because not every study for an ovarian cancer patient has to be an ovarian cancer study. Sometimes if you have an alteration of potential interest, you can be in a phase 1 study that's open to all different types of cancer, but with a drug that's targeting that alteration across different cancer types. And that's really the type of studies that first showed efficacy for MEK inhibitors in low-grade serous ovarian cancer. Before we had that first study of selumetinib, it was larger phase 1 studies that enrolled people with lots of different types of cancer, and then found that the few patients that had low-grade serous ovarian cancer were responding to these drugs.
Mm-hmm. Great, thank you. And speaking of MEK inhibitors, this person is saying that they have no identified mutations. Is a MEK inhibitor likely to be effective, or should one try a combo of MEK plus other drugs?
Yeah, so it's a great question. And so I would say that while the alterations give us important information, one thing we should, in the same way that I think it's really important that we not say chemo doesn't work in low-grade serous ovarian cancer, because it does. There's a good number of patients that have significant responses to chemo. We also shouldn't say MEK inhibitors don't work in patients without MAP kinase mutations, because there's a good number of patients without MAP kinase mutations that have great responses. So for example, that complete responder who I showed you the scans from, who's been on selumetinib for more than 15 years, she had like an alteration that's pretty hard to find. It's not like a regular KRAS mutation or BRAF mutation or anything like that. So it wouldn't show up on a lot of the type of sequencing that people have had done. And she had a complete response to MEK inhibitors. So we have, it's a disease that's driven by alterations in the MAP kinase pathway, and it's not always these hotspot mutations. It can be other alterations that aren't so easily found. And so, yes, I would say that there is still, a good chance of responding to a MEK inhibitor, even if you don't have an identifiable alteration. But at the same time, MEK inhibitor, oh, and I don't even have time to talk about this, I'm sorry, but MEK inhibitors have potential toxicity, right? And so I should have even spoken more about that, since we're talking about MEK inhibitors so much, but they can cause ocular toxicity, they can cause skin toxicity, they can cause swelling, they can cause GI toxicity, decreased ejection fraction, all of these things. So if someone doesn't have an alteration and they're weighing 2 different options of a MEK inhibitor versus treatment with, let's say, letrozole or fulvestrant or bevacizumab plus oral Cytoxan, all of which are good options, they might choose to first go with one of the less toxic options. And so it can help us to decide about what's the best option for someone as an individual.
Great, thank you. And I'm looking at the time, and we probably only are able to get through one more question. So I think just to wrap it up, I would ask you, what's your biggest takeaway for patients diagnosed with low-grade serous ovarian cancer, or something you're most excited about?
Yeah, so I would say, over the past 12 years, I really feel like we've learned so much more about this disease. We're finally completing prospective studies in this disease. We're completing international studies. We're gaining more information about what makes the cancer grow. We're learning what drugs can hit this cancer down. Finally, drug companies are interested in developing drugs for this disease, which is what we need to kind of further development. And so I think it's actually a really exciting time in research for low-grade serous ovarian cancer. And I think we're going to keep making headways and keep making new discoveries and developments. And so I'm so appreciative of our patients who participate in these clinical trials that make this discovery possible. And, I think we're all going to work together to get better outcomes for everyone.
Great. Thank you so much, Dr. Grisham, for an extremely informative presentation and for answering all of these questions. And thank you to everyone who participated today and submitted these great questions. We really appreciate it. Make sure to check out SHARE's upcoming educational programs and support groups and follow us on social media as well. Please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be sent in a follow-up email. All surveys are anonymous, and we really use that feedback, so please take the survey. And that concludes today's webinar. Thank you again, everyone, and thank you again, Dr. Grisham.
Thank you. Bye.